Welcome everybody. Hi Lynn, hi Tina, Avril, Ian, Nick and Nika. Right. Okay. So it's just gone after 1 o'clock, and so that we get a good session on the go, I think we should get started. Thank you everybody that's currently joined us, and hi to everyone that is connecting with us in post on YouTube. It looks like we do have quite a number of people that managed to join us afterwards. So welcome those who are not here in person. So welcome to March's 2018 session on AI in health and social care. Today we have a really interesting session looking at ethics, and going to look forward to having a bit of a presentation and also opening up a conversation with you who are with us on today's session. Just a quick reminder for those of you who are joining us for the first time, this is a session that's quite informal, where people can join in the conversation, and what we're looking for is people to join in via the chat box, which is in the bottom right hand corner of your screen. In there, if you type in your comments and messages, we have a couple of etiquettes just around that, so that if you're writing to respond to someone else's message, if you can just use the @ symbol on the keyboard with the person's name, so that you know that you're talking to that person, or if you want to connect to everybody. Also, sometimes we find, if you haven't done it already, please use the drop down on the send to have all participants, so that everybody gets that. If you do want to send direct messages to myself or John or the speaker, please feel free to do that. And if you want to be unmuted, we can unmute you to join into the live conversation. Hi Lynn. So today we've got myself. I'll be co-facilitating with John on today's session, so please connect with both of us. We've obviously very grateful for Dr. Matt Fenech's time. Matt can be also reached on Twitter. He's a great Twitter user, Matt Fenech83, for some of the work that he's currently doing. If you are connecting with us outside of the room, we use the hashtag AI community if you want to engage or bring anybody else into this conversation that is not aware of what's being discussed, or would like to share some of the messages that we're talking about today. I'm now going to hand over to John for a second, just to give an update on the community and some of the requests that we have as a community in terms of some support. John, can I hand over to you briefly for a couple of seconds?
Sure, great, Dom, thanks. Hi everyone, good afternoon. So in the chat channel, I have put some links, bit.ly links, that will guide you to a Google folder where Dom, I and some others have started collating resources that are available for us all to access, and also you should be able to upload things directly there yourself. Dom and I have been doing this for the last few months voluntarily, and we would welcome any individuals that would like to be involved in particular areas of support in terms of curating the information assets in that Google folder, potentially to help run the webinars and to present in the webinars. We very much would welcome nominations for speakers. In April session, we have a confirmed speaker a medical student who has made, using Google's TensorFlow and some other component parts, a machine learning predict algorithm out at an NHS Hack Day event. And in May's session, we have Professor John Ainsworth, who has kindly offered to present on AI and citizen empowerment. So there are emerging thematics for the next sessions, and if anyone would like to be involved in presenting or to nominate someone else to present, please do let Dom and I know. Thanks very much. I very much look forward to this session. Thanks for all being here.
Brilliant. Thanks, John. And we've got a couple of other updates before we hand over to Matt. One is with Avril. Avril, are you on the line? Can I unmute you just for 1 second, and if you can give an update on your current work that you're doing, that'd be really helpful. Can you hear us, Avril?
I can. Can you hear me?
Loud and clear.
Oh, wonderful. Hi, everybody, and thank you for letting me sneak on right at the start of this. I'm literally in a new stage of creating a brand new tech startup. The intention is to be a central source of information for all the data surrounding cancer, and that's everything from products, services, support, research, being able to filter by your postcode, age, type. And this is because, as you know, there's so many amazing stuff out there, both small businesses, big businesses, charities, communities. It's really hard to know what to find. It's really difficult to know what language to put down. So if you want to know a bit more about Cancer Central, please feel free to reach out and I can share much more on that. But really what I wanted to share here is, Dominic, thank you. You're on the judging panel. I'm delighted to say we're going to have a hackathon. Because it is a community and because we're building it from the community, we're inviting Java developers to come across. They have an opportunity to work with a specialist, an AI specialist from the IBM Watson team, and build the first stage of the product, which will become part of the last site. So it's very exciting. So if you know of any good Java developers, please send them through to cancercentral.org.uk or send them through to me and I'll guide them in the right direction. And thanks, I'm looking forward to having you and seeing you on the day.
Thanks very much, Avril. If it was possible to put a link in the chat channel, that would be great, sort of expediting people to find that information and book into the hackathon. Really exciting stuff.
Thank you, and thank you, Avril, for the update. Really exciting to see this being all connected together as well. In terms of bringing communities together, we also have another update for those of you who are interested in a conversation about artificial intelligence in improvement work within healthcare. The Q community, as part of the Health Foundation, the AHSN network, and the Horizons team have collaborated on pulling together a tweet chat on the 20th of March 2018 at 8 p.m. This is welcome to everybody who wants to have a conversation about improvement practice and what AI means for it going forwards. Now, if anybody else wants to be collaborating with us on that, please let me know and we'll tie you into that wider conversation. But please share this out. I'll be tweeting it out this afternoon to engage with not only those who are interested in doing AI work, but those who are working in improvement and quality improvement. We also have some updates on some of the other programs of work, which we'll do at the end of Matthew's session. So Matthew, I'm going to hand over now to you. If I'm just going to provide you the presenter ball. So just give it a couple of seconds and you can just tap on your presentation and guide us through the conversation about ethics and what you're currently doing.
Great. Thanks very much, Dom and John, for the opportunity to speak today. Can you see the presentation?
You just need to click on the tab there. Matt, if you click on your presentation, through tab.
I have done that.
And let me take the ball back for 1 second, and I'll give it back to you. Everybody should now hopefully see the presentation, and I'll just hand the ball back over to you, Matt.
Perfect. Great. So thanks very much again for the opportunity to present today. So I'll be speaking about ethical perspectives on the use of AI in healthcare, but I thought I'd just take the opportunity to just introduce our organization, Future Advocacy, and a bit more about this project while we're here. So we're a think tank and consultancy. We're based in London, and we aim to really occupy the space between, okay, there's a problem we've identified, and okay, what should we do about it? And so trying to be propositional and doing government-facing and policy-facing work in terms of advocacy. So we have a number of different projects. Two of our major clients are the Jamie Oliver Group. You must be seeing a lot in the media at the moment about, for example, junk food marketing and energy drinks marketing, and that's some of my colleagues who are working on that with the Jamie Oliver Group, and also HIV/AIDS and putting it back on the global agenda with the Elton John AIDS Foundation. But what we're here to talk about today is what is more of our think tank work, which is a project we call Artificial Intelligence, Maximizing Opportunities and Minimizing Risks. We've done a number of different bits of work on this. In October 2016, we released a report called An Intelligent Future, where we made an initial list of recommendations to the UK government, some of which have been followed up on. We did a bit of work with the Webb Foundation, Sir Tim Berners-Lee's foundation, on the impact of AI in low and middle income countries, which of course is a very interesting topic. Many of the issues are similar to what we might find in more developed economies, but there are certain unique issues with emerging economies to cover in that report. And last October, we did a piece of work which was very well received on the impact of AI across the geography of the UK, with a special mention, a special focus across UK parliamentary constituencies, which was well received, got wide coverage in the media, and was a very good way to speak to individual MPs about the impact of AI on jobs and automation on jobs. And all of these are available on our website. We can see the URL in the bottom left-hand corner there. Why do we work on AI? I always put these following two slides up. Partly, this slide is, Stephen Hawking is very famous for making this comment about AI being either the best or worst thing ever to happen to humanity, and I always put this in to remind me that there's a lot of hyperbole, but there's obviously a lot of potential as well for AI. And the second thing is Sergey Brin, co-founder of Google, saying that he was surprised by AI. So to go easy on ourselves, if we're not up to date with how fast things are moving, if even Sergey Brin found it surprising with how fast things are moving. And certainly, with this particular project, it's been interesting how much things have moved since we started the project, in fact. And I'll just mention from my point of view, my own background is in healthcare. So I worked for 10 years as an NHS physician, and then more recently as an academic clinician before moving into policy work. So working on this project has been a really exciting thing for me, essentially. And at this point, I'd like to thank my colleague Nika, who's also joining us in this conversation, who's been working with me on this project. So this particular project has been commissioned by the Wellcome Trust, and what they've asked us to do is undertake a bit of horizon scanning to see where AI is being used in healthcare at the moment, what the potential uses are, really understand the lay of the land. But the main issue is to really understand where the gaps in our knowledge on the ethical issues are. And the reason they do this, of course, the Wellcome Trust is a major health research funder, so they want to be able to construct their grant program going forward based on questions we've identified, gaps in the community's knowledge. And we're doing this via literature review, interviews. We've interviewed over 50 experts, from computer scientists, clinicians, doctors, nurses, other allied health professionals, policymakers, ethicists, and philosophers. The really exciting bit is we've had a really great opportunity to speak to patients, members of the public, patient representatives, so they start getting their views. We've already had a roundtable with a group of patient representatives on the 22nd of February, and we will have a roundtable with experts, including ethicists and computer scientists and policymakers in mid-March. So we're very much looking forward to that. So let's get a bit into the meat of the project. So one phrase which I've been using a lot is trying to separate what is hype, what is hope, and what's actually happening. And you know, I'll be very keen in the discussion about what you think about this classification that we've come up with, but we've identified 5 main use cases for AI in healthcare, and I'll go through each in turn in the next few slides. So the first is around process optimization. This is about the back end of healthcare, and although one would think that it is really sort of low-hanging fruit for the application of AI to healthcare systems, we haven't really found very, very many examples of this in action at the moment. So I put the logo for the Hong Kong Hospital Authority there on the left, because they have a AI system developed by the local city university across 40 hospitals that is determining the rota schedule, shift schedule for over 40,000 employees of the Hong Kong Hospital Authority. And this is not one of the sort of newer machine learning statistical types of AI, but more of the rule-based, good old-fashioned AI. But clearly, it's very sophisticated. It manages to keep 40,000 employees happy. And in fact, according to research that the Hospital Authority has done itself, it says that its employees are happier and more productive as a result of the use of this rostering system. I haven't been able to find real-world live uses of this in other jurisdictions, other hospital systems. So if you have any examples, I'd be very keen to hear about them. And the other example I've got there is Corti. You might have heard of Corti, which is an AI system using natural language processing to listen in on calls to emergency services in Copenhagen. The aim is to use this to assist the emergency service technician, but there is a process element to it, in that it is ensuring that ambulances, for example, are sent to the correct address. It is optimizing the use of ambulance resources in a very Uber-style way, in terms of getting the closest ambulance to go to the call and things like that. So the process of dispatch in emergencies, what Corti are using AI for, amongst other things. I also put in another 2 potential uses there. So, for example, Zara and Amazon on the fly use AI in order to predict demand in their products and make sure that they've got enough of their products in the correct warehouses. You know, this is something that our interviewees and our contributors mentioned could be a potential use in healthcare in terms of procurement, stocks, logistics, supplies, and also the holy grail of natural language processing to transcribe clinical notes on the fly, to summarize and review clinical notes. Again, potential uses, but I haven't come across, or we haven't come across actual uses of this at the moment. The other thing the next use case is in preclinical research. I mentioned Benevolent AI and Teva Pharmaceuticals there. Benevolent AI are a UK-based company which are using AI to screen compounds. Pharmaceutical development occurs via the screening of libraries of hundreds of thousands of potential compounds. The process by which a drug is brought to market is a very long and expensive one, so the use of AI to narrow the initial screen down is something which would be very advantageous to the pharmaceutical industry, and Benevolent AI are making some initial steps there. I put in Teva as an interesting example because they have partnered with IBM to use AI to look into repurposing existing pharmaceuticals. So they are looking at links between, or potential links between existing approved pharmaceuticals and known disease targets which do not have a pharmaceutical treatment yet, and possibly looking at using this to repurpose pharmaceuticals. Again, future potential uses, lots of hype, lots of hope, but no actual real-world uses as far as we know. The use of AI in genomics, sequence analysis, and then eventually personalized medicine. Also gene editing, so we've all heard of the revolution around CRISPR. Could AI be used to identify targets, which is a very laborious process in CRISPR? Could that be used to identify targets to speed up this process and eventually develop treatments based on gene editing? Very much not on the horizon, but a potential use, but not actually happening at the moment. Clinical pathways, so what we're talking about here is about AI tools that are used within a defined clinical pathway, so a diagnostic pathway, maybe a prognostic pathway. And I put, again, 2 real-world uses in the pictures there. On the left, there's Viz.ai, which has recently been approved by the FDA. And as you can see there, what it does is review brain scans for sign of a stroke, and if a sign is identified, send a SMS or a notification message to the treating clinician's smartphone. So the idea would be that you have radiological, machine vision technology applied to radiological imaging to prioritize scans for review. And I put the Viz AI there because it's, as I say, just been approved by the FDA. On the right, you've got an OCT image. OCT is an imaging modality for the eye, and I put that because we know about the collaboration between DeepMind and Moorfields Hospital. We had the privilege of going to visit Moorfields and speak to Mr. Pierce Keane, who's leading on this project over there. And it's very exciting that they appear to have some really interesting results, which they've submitted to a journal, a major peer-reviewed journal, of the real-world applications of this tool, which once again would pre-screen OCT images in order to identify those which need urgent input by a clinician. So we really, very much watch this space to see how that tool might start being used clinically. The other thing I put in text there is about prognostication. There's been a couple of studies released in the last few months from Stanford Hospital, for example, in the States, on using AI tools to predict all-cause mortality, and also other tools here in the UK looking at echocardiograms to predict cardiovascular risk. So once again, you can imagine these individual tools being interposed into clinical pathways. Patient-facing applications, so this is where we're talking about things that interact directly with patients and with service users. On the left, you've got the logo for Ollie, which is a chatbot that is being used and has just gone live in a beta version, but gone live at Alder Hey Children's Hospital. Again, we had the privilege as part of this project of going to visit the team there, and Carol Platt and Ian Hennessy were very kind in speaking to us. And what Ollie does, it's been developed in partnership with IBM, with Hearttree Center, and it's a chatbot that patients who would be children in Alder Hey, their relatives, their parents, can interact with via an app on their smartphone or their tablet in order to ask questions about their hospital stay. Everything from where is ward G3 to what is a blood test, will it hurt, and these type of things. And the AI there is about matching, using natural language processing to understand the question and then matching it to the most appropriate response. On the left, you've got a Minimed 670G pump by Medtronic, which is an autonomous closed-loop system to deliver insulin to type 1 diabetes patients. Again, that's FDA approved. I don't know if there are, I don't think there are, actually, there are no pumps, autonomous closed-loop pumps, which are used routinely on the NHS. But what's very interesting in the insulin pump space and the artificial pancreas space is the open APS community, which is a community of patients, type 1 diabetes patients, and their relatives, predominantly parents of children with type 1 diabetes, who are hacking into existing insulin pumps in order to make them closed loop and autonomous. And they campaign under the "We Are Not Waiting" hashtag to say that, we need the technology now, basically. So that's a very interesting thing that we've come across in our research. In future, could we have robot carers? The Japanese government has, as part of its policy, it's written into its policy for the next legislative period, that by 2020, 4/5 of care of the elderly is delivered with some form of robotic assistance. And that seems like a massive statistic. And then you remember, of course, the population time bomb that Japan and many other developed economies are sitting on. And robotic surgery, very much in the future. Other things that we came across is the use of smart homes, where the combination of sensors throughout the home and wearables would be able to help vulnerable people such as patients with dementia and other forms of cognitive impairment to live in their own homes for longer, send alerts to their carers when, for example, they fall or they seem to be behaving abnormally. So that's something which, for example, we spoke to a team in Swansea that is researching these tools at the moment. And lastly, population level applications. So this is one where it seems once again that it should be obvious that AI could be used, but we found very few actual real-world uses of this. One thing I will say is that mobile phone data, for example, has already been used to retrospectively model outbreaks of cholera in Haiti in 2010 and dengue fever in Pakistan in 2013. So in theory, one could use social media, mobile data, search trends to map epidemics, for example. But we remember the case of Google flu trends, which in 2013 massively failed to predict a flu outbreak that year. So clearly more work is needed on this potential population level application of AI to parse through big data on health searches and things like that in order to predict the onset of infectious diseases and other public health threats. So onto the ethical perspectives that we're thinking of. And the things to say is that these are very much open questions. I hope that we'll have some discussion after this to be able to talk about it. And I've got some questions, in fact, that I'd like to address in discussion at the end of this presentation. So one thing that has come up is, what do patients and members of the public really want from these tools? How do they think we should be using them in health and medical research? And how comfortable are they with sharing their medical data in order to train and develop these tools? And in fact, and it was actually patients we spoke to that said, patients may be a different community from other members of the public, and we're quite used to maybe as healthcare professionals interacting directly with patients, but what about people who don't identify as a patient? There's an argument, of course, that we're all patients in some way sooner or later, but there's a clear, perhaps, distinction between people who identify as patients and people who don't. And how do we reach out and understand what maybe these different communities feel and think about these tools? And we've done, as part of this project, some initial work. I'll also mention that the Royal Society did a very good survey on machine learning and public attitudes to machine learning last year. It was actually a 2-year project starting from 2015, where they have some really interesting data on what the public think of machine learning in health. But we did a YouGov poll last year, where we did a couple of questions on health. And the first one is an interesting one, where we asked people, should AI be used to help to diagnose disease? And should AI be used to take on other tasks performed by doctors and nurses, such as giving information, breaking bad news, suggesting or implementing a treatment pathway? And I hope you can see what a big difference there is there. Just over 40% of people thought that AI should be used to diagnose disease, but then only 17% thought it should be used to take on other tasks performed by doctors and nurses, and a whopping 63% thought not, that they shouldn't be used for these other tasks. So clearly people distinguish between the different tasks that healthcare professionals do. And this slide addresses the data from another question we asked, where we said, how comfortable would you be with your personal medical information being used to improve healthcare? And as part of the preamble to this question, we said that it's never possible to guarantee 100% data security. I apologize if there's any noise in the background. It's never possible to guarantee 100% data security. But in spite of this, would you be comfortable with sharing your personal medical information to improve healthcare? And 49% said they're not comfortable, but a significant proportion, 40%, said they would be comfortable. What I will mention about this poll is that's a YouGov poll, 2,100 adults aged 18 plus, a weighted representative sample of all UK adults. So we think it carries some weight in terms of indications, but clearly it also raises interesting questions that deserve further exploration. Another question that we've come across is, or rather we've been thinking about and talking to with the contributors to this work, is just because these technologies enable access to new information, is that always a good thing? Should we always use it? And it's put me and Nikan and my colleagues in mind of the issues around genomics, for example. There's a lot about genes not necessarily being destiny. Just because you have a particular gene, it doesn't necessarily mean, depending on, of course, the gene, the condition, and various other factors, that you or your relatives will develop this particular condition. So in fact, there's a lot about genomics and genetic counseling in giving people the right information at the right time. Also, maybe, what is the usefulness of information of screening tests when you can't do anything about the outcome, where you're told you are at risk of developing a condition and then there's no treatment or inadequate treatment for it. So this is putting us in mind of the various prognostication tools that are being developed, and particularly the things I had in mind are tools, for example, the one in Stanford that I mentioned earlier. There's another tool being developed in the private sector that parses through electronic health records, unstructured electronic health records, to predict all-cause mortality in the next 3 to 12 months in the case of the Stanford tool. So this raises interesting things. So the Stanford team are using it in the context of their palliative care team. So it's very much in the experimental phase at the moment. What they're doing now, having published their work in ArXiv, I don't think they've published it in a peer-reviewed journal. What they're doing now is linking it up with their palliative care team to see if the tool can be used to direct limited palliative care team resources to the people who need it most. That is, the people who are identified at highest risk of all-cause mortality in the next 3 to 12 months. But is there a risk that people might be flagged as being at risk of dying, and therefore decisions are taken about their care from active treatment to palliative treatment without their involvement? And if, I realize this is speculation now, but if the tool gets more and more accurate, and now we're in the realms of philosophy, and you could predict, your time of death to the next week or much smaller time frames, is that level of information a good thing? Would you want that information? Would people want that information on balance? So these are the type of, again, questions that we think these developments raise. Of course, no discussion on technology is complete without a discussion of regulation. So our current regulatory frameworks fit for a purpose. As healthcare professionals, we have a good understanding what duty of care means. But in this world where developers from outside the healthcare sector, obviously with the best will in the world and doing it for all the right reasons, maybe from the private sector, from universities, are partnering with healthcare professionals in order to develop these tools, how does the duty of care extend to the developer? Is it just a transaction relationship where they develop the tool and then sell it or give it or whatever to the hospital, and then it's the hospital responsibility? Or does the developer, the computer scientist's duty of care extend beyond that? And people are in fact mooting Hippocratic oaths for computer scientists, for data scientists. Is this the type of thing we want to be thinking of? And then I've got a list there of current UK regulators, so the MHRA, CQC, GMC, NMC, ICO, new regulators and centers of policy centers in AI, the Center for Data Ethics and Innovation, Convention on Data Ethics, Government Office for AI. I've added the last acronym myself because how are all these regulators, and this is just in the UK, of course, going to interact to regulate these tools to ensure that they, benefit patients? One thing that comes to mind here is something that a consultant of mine used to say, that shared responsibility is shared neglect. How do we make sure that one regulator or a clearly defined chain of command, a regulatory chain of command, comes across to make sure that these tools are properly regulated? Again, data is a very interesting and important point. Medical data has been a long-standing issue in terms of the ethics of the use of medical data. We have very good regulatory frameworks in the context of using medical data for research. How are these going to be impacted by AI? How, in fact, is medical data from other forms of personal data? It's interesting, for example, that GDPR extends the definition of personal data extremely widely. And in fact, you think about how much data is shared on social media and how much of that can be used to identify you. It's maybe, you could argue that that is more personal than your blood pressure readings or your blood glucose readings. And yet there's something about personal data which makes it seem more personal and more confidential. Maybe there's different stratifications of personal data in terms of their confidentiality. Likewise, what's the most ethical way to collect and use large volumes of data to train AI? And this is something which other fields using AI are grappling with at the moment with GDPR. The consent model, I mean, the ICO, the Information Commissioner's Office, states that the consent model is not good in this context simply because of the huge quantities of the massive data sets that we use in current forms of AI. So what's the most ethical way if we're not going to get explicit consent, which of course we're used to in research, in medical research, we're used to really being very careful with consent. And how do we ensure value for the patients or in public healthcare systems like the NHS for the taxpayer? We don't want situations where companies, other organizations come in, use the data, say thank you very much and go off and license and sell the tools without any value back to the patients whose data was used to train the system, or the taxpayer who funds the NHS in our case, for example. And lastly, it's a really interesting thing that we've been discussing again with our patient representatives, how these technologies might address or potentially worsen health inequalities. We know that health outcomes differ, across the UK, let alone across the world. Are these technologies a good thing in that respect? Are they empowering for patients? Will they rebalance the power relationship between patients, their carers, their relatives, and healthcare professionals who are delivering care? Will they make healthcare more of a partnership? Or might there be populations which may be excluded from these technologies? Is digital literacy going to be a major issue in accessing healthcare technologies? How can these populations who we might identify as being at risk of exclusion, how might they be included? That's really the end of the presentation. What would be great to come across in the discussion is, your thoughts on what we might have missed, really what is most important, urgent, pressing, what you think we and others should be researching urgently in terms of the healthcare context, and who else we should be speaking to. And I've got my email and Nika's email there, and Dom has already shared my Twitter handle, so please do get in touch, and we'll be keen to hear more. But I look forward to speaking about these things in the rest of the discussion.
Matt, thank you very, very much. That was there was a lot to consume there, and I have many questions myself. As we can see through the chat going flying past there, there's quite a number of questions as well. So first off, thank you very much for giving up your time to present on this. And for those of you who are watching this in post, feel free to connect with Matt directly to follow up on some of the questions and connect them into some of your programs of work. Does anybody want to ask any specific questions? John, have you seen anything in particular? I know you've been following the chat quite intensely in terms of what to ask. Any questions?
Thanks, Dom. Yeah, so interesting threads of conversation in the chat channel. Thank you very much, Matt. Really interesting presentation. There was an initial list of 5 points early in the presentation. I'll just jump back to the landscape. 5 main use cases identified: process, preclinical, clinical, patient-facing, and population-level applications. In the chat channel, it has been mentioned maybe considering personal pathways, but also potentially career pathways in addition to those main use cases. Any comments or responses to those suggestions, Matt?
Yeah, that sounds like a very excellent ideas. So personalized pathways, is that about, I'm not sure, who might haven't caught up with the chat, but is that about personalized medicine and sort of more patient autonomy? Would that be sort of subsumed under the patient-facing applications category we've got there. And also maybe with the career pathways, would that be more about process and human resources, that type of aspect of healthcare, or is there something separate?
So I've just invited Lynn to come in this voice conversation, because the suggestion of personal pathways was made insightfully by Lynn. Lynn, would you like to join this? I don't want to assume that I understand the so Dom, could you unmute Lynn, please? Is that possible, Dom?
Yeah, I'm just doing that now. Liz, if you can mute yourself as well. Lynn, you're live.
Okay, thank you. Can you hear me, Dom?
Loud and clear. Welcome.
Okay, it was actually about the wider determinants of health and care. Clinical always feels very medical, and of course, if we're looking at an individual and their health and well-being, yes, personalised approaches, but also cognizant of the wider determinants of health and care, optimising health and care. And it wasn't my point about careers, but I wonder also if it was a typo. It might have been carer, but I could be wrong. I don't know who it was that made that point, but my point was about substituting a different word for clinical, just to be, because the heading is about AI in health and social care. So as the adult social care representative, obviously I'm going to jump in there with this point.
That's a very good point, yeah, Lynn. Yeah, no, thank you. That's a very, very good point. And you're right.
Thank you, Lynn.
I sort of use clinical in a wide context, but I understand the connotations, and that's a very, very good point.
Looks like Sophie's got a question as well. Sophie, do you want to come on, or shall I just read out your question? Comment here is, I think, a significant issue as to whether or not the voice of the user is part of the design process. There's a broad question of where in the application of AI technology responsibility actually lies. Do you come across any thoughts in your work currently, Matt, in terms of where does the responsibility lie?
Yes,
I think Tina's questions about which organizations are currently responsible for this piece of work as a overall. Sorry, jump on.
Yes, no, I think that's both extremely good points. So Sophie's point, you know, we're real advocates of this, and we hope that this will come across in the report and you know, subsequent work that will be done in this, is that it's so important to involve patients and clinicians, and again, I use the word clinicians in the widest possible sense, nurses, doctors, all allied health professionals, social carers, everything, essentially everybody, in the design process. There is something about the technology industry which is falling in love with the solution rather than the problem. Say, we love the tech, let's see how to apply it to all of these different things and see what works. Moving fast and breaking things is the mantra in Silicon Valley. We and others, and hopefully you agree, don't think that this is the model we should be applying in healthcare. It must be a much more participative approach. And certainly we've come across two really good examples of this. So in the UK, DeepMind Health does regular sessions with patients, members of the public who are contributing to their own work. So that's something which you know, seems to be a very good model. A really interesting bit of work we came across, actually, in the use of AI and predictive analytics in social care, is in New Zealand. Professor Rima Vaitanathyan's team, and they have developed tools. And you may be aware that particularly in Maori communities, there are many issues with social deprivation. They have developed tools which address an extremely controversial topic, which is child abuse, essentially, various forms of child abuse, emotional, physical, and sexual child abuse. And they have developed tools in order to predict which families may be most at risk of this happening. Now you hear that and you say that, you know, how can you label families like that or things like that? But speaking to Rima and her team, and the way that they did it was to, before developing the tool, go out to the Maori communities. And these are communities which, as I say, have problems with social deprivation, the health effects of social deprivation. They are very suspicious of, inverted commas, the government, authority, and you know, the story that has come out, which hopefully will bring across in our report, and which their publications coming out soon should bring across as well, is how this participative approach, you know, really helps, and the people that they spoke to told them this is what we would want from the tool. This is how comfortable we are with sharing our data to develop this tool. We see the value of this tool. So we think that there is good examples out there. There's clearly also very bad examples out there. We don't need to necessarily mention them by name, but of tools where the technology is developed first and then we try to tag it on to the clinical pathway afterwards. About who should be responsible, we've asked this so much, sorry, in terms of regulation, which body should be responsible in terms of regulation. We've asked this so many times to our interviewees, and nobody, well, certainly the MHRA is looking at regulation in the context of its devices, so software is considered a device, but speaking to people at the MHRA, they realize that the current scope of regulation will need to be extended. It needs to interact with European regulation, although that of course is complicated by Brexit. We know the FDA is developing a new way to regulate software at the moment, and we know that one of the outcomes of that has been the approval of Viz.ai that I mentioned for analysis of CT scans of the brain very recently. So it's not clear who should be, but we think that, you know, somebody needs to be an obvious point of contact for this.
Thank you very much. John, you wanted to jump in, and then I think Mark wanted to say something, and then we're heading into our last few minutes. And I would like Tina to give an update on programs of work that are currently happening. So if you've got any questions, put them in the chat box. But John, over to you, and then over to Mark out with it.
Brilliant, thanks. So Matt, I wonder if you could comment on the notion that beyond a Hippocratic oath for developers and data scientists, it might be timely to start thinking about Hippocratic principles encoded in algorithms and licenses. Yeah, I could elaborate if that didn't make sense, but it seems that there is a lot of anthropomorphization of these AI systems, and the idea that it might be the systems that have a sort of Hippocratic oath of some sort encoded into them. Any comments on that?
Yeah. So that's a very interesting approach. We've discussed it with some of our contributors. I will confess to being an enthusiastic amateur here, so I'm not a computer scientist, as I made clear. So, you know, my background is in healthcare and in policy, so I don't know about the technical solutions here. But one interesting discussion that came up with our interviewees and with our other contributors is about the type of AI used here. Of course, you know, machine learning, statistical techniques, maybe dynamic online learning systems are the I hesitate to say sexy thing at the moment, and the thing that everybody's talking about. But we need to remember that good old-fashioned AI, rule-based, symbolic, logic-based AI has been around for much longer. Well, even machine learning has been around longer, but it's sort of come back to prominence recently. But people have been using good old-fashioned AI for health applications for some time. We came up across examples in the mid-80s, John Fox and his team using these. So one discussion that we've had is whether we should be using more of these complex decision tree rule-based systems, because they are easier to imbue with these values. Again, I don't know about the technicality of that, but certainly the more statistical methods are more about presenting a mass of data and seeing what patterns develop and patterns emerge. And that might be useful, but when it comes to the final application, having a more complex rule-based tree might be an opportunity to put in these Hippocratic oaths, these principles into the system. You know, some people we spoke to went as far as saying we should not be using deep learning, we should only be using rule-based symbolic logic systems. I don't think I'd agree with that. I think you'd miss out on all the great opportunities that deep learning provides in image analysis, for example. But there's something here about how you put in these values in the system, and technical solutions have been proposed here.
Brilliant, thank you very much. Yeah, accessibility of the public to these different intelligence systems seems to be a pressing concern. Thank you for that insightful answer you've just given.
Very helpful, thank you. And Mark, I'm just going to unmute you now if you wanted to talk about one of the comments you made.
Yes, thanks, Dom. It was just really an observation, and it was triggered by the slide about the survey and sort of public response to use of AI. We tend to sort of get the answer to the questions we ask, and we want to be careful that we don't use surveys like that to prevent us making progress. And the example I would give is I think you need to make a distinction between what I call the software layer, the AI layer, and the interface layer. And actually, it's entirely possible that the interface layer is actually a doctor or a nurse, supported by it. And we just want to be very careful. If we ask the wrong questions, we're going to get nuanced and the wrong answers. And one of the interesting areas of travel is the extent to which doctors, nurses, clinicians feel enabled and confident to use AI as part of the consultation and treatment process. And I suppose there's one other point, is that also is to get a commercial return on investment. One of the things you need to be thinking about is the distinction between the AI layer and the interface layer. So, can you be consistent with the AI layer, internationally? Is the cultural sensitivity of the interface layer that is the important bit. You can't develop a different system for each and every culture or health system.
Totally.
Yeah, if I could just add on to that, I mean, those are great points, Mark. Thanks for making them. I think maybe I didn't make it clear in the sort of personalized pathways, or what I called clinical pathways section in my presentation. But yes, very few serious people are talking about AI replacing doctors. We know, and healthcare professionals, we know that healthcare, a job can be split into various tasks. And in fact, the wider discussion on the automation of jobs has moved from replacement of whole jobs to replacement of tasks, and healthcare is no different. So we are very much seeing defined tools that are interposed and interpolated into the clinical pathway. And at least the ones we've come across are very much upstream of what you've called the interface layer. And you're right, that question doesn't have the nuance to distinguish between that, but one interpretation is that people would be happy to have it in the back end diagnosing the disease, maybe with greater accuracy than the human operator. But then in terms of the interface, so giving information, delivering treatment, breaking bad news, then they wouldn't want an AI there. The interface has to be human. So I like that distinction between the software and the interface. And my interpretation of that data, but I completely take the point, is that it opens as many questions as it answers, is that people still want the human interface. And again, this is something which has come up, and I think is an open question which definitely deserves further exploration.
Thank you. Matt, thank you very much for your time today. I really appreciate it. I'm sure there's going to be many more conversations we're talking about following up on some of these bits. I hope this has also been helpful for you in terms of your research, and also feel free to connect with anybody in the community that you feel is relevant and helpful to this wider conversation.
Thank you very much. Thank you.
Before we finish for today, I just wanted to do a quick handover to Tina, who's going to give an update on one of the programs of work that we started kicking off a while back. Tina, let me just find you on the list and unmute you. Here we go. Tina, can you hear us?
Yes, I can hear you. Can you hear me?
Loud and clear. Go for it.
Excellent. So I'll just put my camera on if that's helpful. Yeah, so I just wanted to update. Some of you may have heard this already if you were on the last webinar, but I'm working with the Kent Surrey and Sussex AHSN, who are taking, I guess, the overall AI sort of national lead on the AI ecosystem project, and working with Dom Cushnan, Melissa Ream, and a number of other individuals, to make this happen. And just to give an update, and we'll be in touch with all of you in due course, we're at the stage now where we're essentially sort of in a consultation sort of process, working with a number of individuals who've been very active in this space. We've even talked about Viz.ai, Manoj Ramachandran, who are in touch with, and many other individuals who at the moment are helping us with the development of a survey that we're going to be unleashing at the end of March, and want to be asking, and I think a lot of the questions that came up today on the ethics piece, and Matt, really interesting to hear your work, and we'll definitely pick up with you after the call as well, because I think the ethics questions are really, really crucial for some of the issues we want to find out from the survey. But essentially, the survey is very much part of building up a map of where AI is happening against a taxonomy that we're currently preparing, sort of, in terms of being very, very clear on what we mean by AI and machine learning, etc. And looking at where AI is happening, both within the system, as it were, but also outside, mapping that, getting an idea of where it is happening. And then through the survey, we want to identify sort of key barriers and opportunities to develop an AI ecosystem, make it easier for AI to happen in the system, and look at where the obvious use cases are, where it's going to deliver the most impact, for the NHS. So really interesting to hear, what you were saying today, and we'll probably be in touch. And and indeed, we want this community to be informed, through everyone, essentially. And this survey will be one mechanism to do that. The intention then is to create a report that we'll be launching. The current plan is at Expo in September, NHS Expo. So obviously this community is a big part of it. We hope that everyone who is participating in these communities will get involved in the survey and mapping exercise. And we want to hear your voice. And we need these voices to help us steer the future, which is really exciting. There's so much. It was interesting. The real world applications are just starting to happen, but obviously, we're at the cusp of quite an exciting time.
Thank you, Tina. And for those of you who haven't managed to reach out to Tina yet, who's leading on this work for the HSN network, please feel free to do that. I know, Lynn, you're holding the fort for social care, so please connect, and anybody else who hasn't done so yet. Guys, we're finishing up now in the last few minutes. If anybody has anything else to say, please continue to chat into the chat box. Just as a reminder, there's the AI tweet chat on the 20th of March, which is through a number of different organizations with the hashtag AI community. You can follow up and connect with each other on Twitter with the hashtag AI community. And we also have the Facebook group, which is a closed group, and really welcome some conversations, some shared content in there. Any programs of work that you're currently working on that you feel is relevant for this community and for colleagues, please let us know directly, or feel free to just use the hashtag and the group to do so. On that note, thank you very much for Matt and for all of you who have joined us today, and look forward to a continued conversation. There will be invites out for the next session and speakers, but as was mentioned at the start, if you do have capacity to help facilitate and get engaged in bringing speakers on board, John and I would be very much welcome to support us. So thank you very much, and have a good week, and I shall speak to you all soon.
Thank you very much, all. All the best.